Medicaid, which is really going to be an overview. You can go as deep as you want, as complicated as you want in Medicaid, but we're going to stay right up here just to give everybody a taste of how the Medicaid program works. So you've got some handouts, and I've got the slides up on the screen. Let me know if you have any questions. So just starting out, Medicaid is at least legally a partnership between the federal government and the states. Sometimes that partnership works really well. Sometimes it works not so well. Sometimes there are tensions. Generally speaking, the federal government sets the basic criteria for the Medicaid program. They tell us what the minimum eligibility categories are, who minimally is going to be eligible. They tell us the mandatory benefits that have to be provided, what services are required. States can add to those if they like. They can add groups of people to bring them into Medicaid. They can add services if they want. The federal government generally provides matching funds for the Medicaid program in addition to setting the basic criteria for it. Currently, the federal government pays 61% of every dollar that is spent here in Florida, and the state pays 39%. Now that fluctuates every year because that federal medical assistance percentage, or FMAP, fluctuates each year because it's based on the average per capita income in the state. So poorer states like Mississippi or South Carolina have much higher FMAPs. Those two states are in the 70s. So that fluctuates a little bit depending on the economy of the state at the time. And of course, if a state fails to comply with any of those federal requirements, there is potential in the law for the state to lose all of the Medicaid funding that the federal government sends. This slide's just a few quick facts about the program to give you a sense of the size of this program, which is enormous. It covers 1.7 million adults, 2.3 million children, and that children number is really important because it's increased tremendously in the last year. In 2015, there were only 1.8 million children signed up, so we've increased the number of children covered by Medicaid by 500,000 children, from 38% to 46% in a year. Well, the question is, to what do we attribute that increase? In general, not everyone who is eligible for Medicaid signs up. It's usually about 79–80% of the people who are eligible. I think recently there's been a lot more awareness about the importance of healthcare coverage. So we're seeing parents sign up their children. They were always eligible, but they just didn't come in and sign up. So from the children's perspective, no need, perhaps. The parents thought it was unnecessary, or perhaps they had other forms of coverage, or perhaps they just weren't aware that their children would be eligible. This is the so-called woodwork effect, correct? Right. That's right. So you see consistently who generally shows up, but because we've had maybe more awareness of health insurance coverage lately, we're seeing more people try. We're also seeing some transfer from the exchange. So when people hear that the federal exchange has coverage for them, they go to that exchange. The federal government may find that they're not eligible for those exchange subsidies. They're actually eligible for Medicaid, and they'll kick it over to the state. So we see some increases as a result of that as well. Yes, sir. I don't recall the rate in 2008. We can get that for you, but it does fluctuate. I don't recall what it was at that time, but it does fluctuate. The FMAP is based on the entire population's per capita income. It's not based on the income of the recipients, because that will stay the same. The income of the recipients constitutes their eligibility for the program. Sure. And you'll see there that 61% of nursing home bed days are paid for by Medicaid, and 63% of the childbirths in Florida are covered by the Florida Medicaid program. This is the complex and interesting eligibility chart for Medicaid. It outlines that federal-state relationship a little bit here. So you see federal law currently requires Medicaid programs to cover low-income children, low-income pregnant women, low-income elders, and disabled adults. So those green areas reflect those federal mandatory categories. The orange and gray areas show the groups of people that Florida has chosen to cover over the time. Those are optional coverage groups. So you can see the big gray chunk there is us choosing to cover children up to 200% of poverty. The orange areas is us adding elder coverage and the breast and cervical cancer program and a little bit of coverage for low-income 19 and 20-year-olds. So you can see on the right in the small box there with the dollar amounts, that's the federal poverty level for 2016. That gives you a sense of what family size constitutes what poverty level. And then the left axis is the poverty level for the eligibility. This shows the growth in Medicaid caseload over time. You can see that it is going up over the last 25 years. See a little bit of a dip there in the 2006 area. You can see that's where the economy was doing pretty well. And people maybe left Florida. But then you see the caseload significantly increase. It does trend with population, that's the question, but it also trends with the state of the economy. And the woodwork effect, as Dr. Pigman noted. More awareness means that we're probably signing up more than the traditional 80% that were eligible previously. Yes, sir. Why, yes, there is, momentarily. The next slide just shows caseload by the eligibility groups that we've talked about. So the green and red areas are your very low income families. You've got your Social Security income folks, long-term care folks. It just breaks out by different groups. Here's what we see with that caseload over time in terms of the chunk of the total appropriations that Medicaid reflects. And you can see that dark blue area has grown over time. This reflects the idea that Medicaid is an entitlement program. If folks are eligible and they sign up, we cover them. We haven't really added to eligibility groups over time. It's just a question of people arriving. And here's your cost chart. Right. There's nothing in this presentation that costs out expansion. This is only reflective of the current program, the current law. Now, when we went through some sessions on that, there were some cost estimates of expansion and some models of what the Senate's expansion proposal would look like. We still have those in the past. There are some state costs involved. States have to pay 10% of those expansion costs. So those estimates are available from last year and the year before, but I don't have them here. Happy to. Of course. So you see the service expenditures go up, that matches the caseload. The next slide just shows you where those expenditures are. So the purple area are the children. They're the biggest eligibility group. Now, for healthcare, children, generally speaking, don't cost that much. They need checkups, they need immunizations. Unless they're in a medically fragile state, they have major healthcare issues, they're not terribly expensive. So you see in the right-hand bar, those are the expenditures. And the children is a much smaller box compared to their size. The blind and disabled is the green box. It's a pretty small eligibility group, but you can see that they cost a bit because that's a fairly high need, high utilization. So the numbers of the people don't necessarily reflect the numbers of the dollars spent on them. So for the last 10 years, Florida has been engaged in a wholesale reform of Medicaid. And it takes 10 years because this is an enormous program and it takes a long time to turn a ship that size. So to understand what we have now, I think it's helpful to understand what we used to have. Prior to the reforms we've been initiating, the Medicaid program in Florida was a very complex system of eligibility groups, financing, various models of service delivery. We had basically a patchwork of fee-for-service models and managed care programs. Medicaid was mostly fee-for-service. That's a model where each provider is paid for each unit of service directly from ACA. There's not really any coordination of service between those providers, and there's no one for ACA to hold accountable for performance. ACA had to manage over 100,000 individual provider contracts, which, perhaps not the most efficient way to manage a program of this size. We did have some managed care. There were 24 managed care organization contracts, but it wasn't really a great model of managed care. So you can see some of the things that were missing in that model on the slide. The economic incentives were really important here. The payment system that we used then didn't really reward plans that performed well or penalize plans that didn't perform well. And to be quite frank, I don't think we really knew what we were buying. Are we buying something that's useful? Are we buying something that's not useful? It wasn't clear. There wasn't much data. So in addition to the fee-for-service and managed care contracts, ACA already also managed more than 150 separate vendor contracts for projects and special issues that the legislature required them to implement. We also had more than 20 federal waivers. So every time a state wants to do something a little different than the federal law requires, they have to ask for permission from the federal government and get a waiver of that law. We had more than 20 of them, all being administered in different places across the state for different subgroups of eligibles. We also had a lot of pilot programs. I think in common parlance, a pilot program is something that you do temporarily to experiment with something or learn about a different way to do something. Well, we had all these pilot programs and they went on for decades, and we never decided whether they worked or didn't work or should be expanded or ended or not. We just carried them along. So ACA was carrying quite a load of all kinds of different things that nobody really knew whether they were working or not. In 2010, the House of Representatives was gearing up to try and figure out what the statewide reform should look like, and we hired a consultant, a national level consultant who had worked in a lot of states on Medicaid. And that consultant took a look at our program and told us that our program was the most complex, convoluted program they had ever seen in the country. So what did we do? The legislature in 2005 started a pilot program, a real pilot program, a real experiment. 5 counties, it was intended to be for 5 years, it had 5 objectives. The 5 counties were Broward in the first year, and Baker, Clay, and Nassau, and Duval the second year. So there was a goal of trying to experiment with this in a more urban county setting, both in Duval and Broward, and in a rural setting, so we could see what worked. Broward, Baker, Clay, Nassau, and Duval. So that started in 2006. You can see the objectives of the pilot there. According to the data that came out of that pilot, and the state reported to the federal government quarterly and annually on this, the data indicated that the plans did provide services that were not previously covered at no cost, that the number of physician specialists increased in several areas. Utilization data indicated that there was some better performance on national standards for quality, which really had not been measured before in the Medicaid program. And a study by the University of Florida showed that there was increased consumer satisfaction in the program. But most important, we learned some lessons. We realized that the market, particularly in Broward, was a little too volatile. The pilot let any plan come in that wanted to do the work. And at one point we had 17 plans in Broward. Plans were coming in, plans were going out. There was a lot of volatility in the market. So that was something that we needed to take a look at. We also had an opt-out option in which Medicaid recipients could use the Medicaid dollars to purchase employer-based coverage. Take-up rate on that wasn't great. It worked for those who did it, but we didn't see a lot of it. And that may have been a design issue, it may have been a marketing issue, but either way, we didn't see that work too well. One of the other things we learned was that Sure. The question is the data available from the reports from those 5 counties? Yes. ACA had to report quarterly to the federal government, and all of those reports were published online. The University of Florida studies was conducted by a unit at the University of Florida that specialized in Medicaid and Medicare studies, and those are online as well. We can try to provide you with some of those if that would represent them. Because children's health care doesn't cost much. I know that might be a surprise to parents, But relative to, if you think about folks in nursing homes or people with serious disabilities or older adults who have chronic diseases, children are relatively healthy. They need checkups, they need immunizations. They don't need a lot of some stitches and broken bones, right? Exactly. It certainly costs more. It costs more than not covering children, but it is they are less expensive than other participants in the Medicaid program, and we. It's not less expensive to cover more.
Relative to other increases.
Children are less expensive than adults. They're lower risk. That's right. So we talked about the Medicaid reform pilot. We talked about the lessons that we learned. What did the legislature do with the lessons from that reform pilot? So in 2011, the legislature took those lessons from the reform pilot and moved them statewide with some changes. So now we have fully integrated, comprehensive Medicaid managed care, including long-term care, with very few exceptions. The exceptions to managed care are things that eligibility categories that don't really make sense to use managed care for, like the family planning waiver. People who are eligible for only contraceptives aren't going to benefit from care management. In addition, I mentioned we have integrated coordinated care. The idea there is that plans cover all services. So we no longer have 150 vendor contracts for different kinds of services, a separate contract for transportation, a separate contract for mental health. We have one plan that covers it all, that provides transportation, that is supposed to coordinate that care and can be held accountable for that care and the coordination of that care. We improve the economic incentives. One of the things we learned in the pilot was that clinically risk adjusting the rates worked. In our old Medicaid program, when we set the rates for managed care, there wasn't any differentiation between the patients. There was a small adjuster for age, children cost less than adults, a small adjuster for geography, Miami costs more than Hendry, but we really didn't look at the risk level of the patients that the plans had enrolled. So there was an incentive in the old Medicaid program for plans to cherry pick the healthy patients. If they sign up children and healthy adults, they can make more profit off of that capitated rate. We want them to focus on the sicker adults. We want them to improve health care for the people that need improvement. Clinically adjusting the rates pays the plans for the risk that they have. So if we're paying them more for the disabled and the chronic diseased adults and those folks, they have an incentive to improve their care because that's where the profit motive is. If they sign up all children or all healthy adults, there's no room for profit there because the rates are lower there. So we use the profit motive to create the incentives and the disincentives to get better performance. And that was one of the things we saw in the reform pilot. Some of the plans didn't adjust their business model well when we flipped how we calculated those rates, and they didn't succeed. Some of them dropped out of the market. The ones that figured out that the way to make profit is to help us take care of people well, they did well. They succeeded. So we continued that in the statewide Medicaid managed care program. We increased the fiscal account. It started in 2013. The law was passed in 2011. It takes a couple of years to get these things off the ground. They started implementing in 2013 and completed implementation towards the end of 2014. We increased the fiscal accountability. We increased transparency. In the reform pilots, we started collecting encounter data, which we had never collected before. Now we can see what the performance looks like. Now we can see who's buying what, how many people are using this service, and is it working? That encounter data is made publicly available through some quality metrics that ACA is publishing online. That's a lot more financial reporting from the plans, information that we didn't receive before, so we can see how they're doing. It includes a medical loss, how the plans are doing, the Medicaid managed care plans. It includes a medical loss ratio, which requires them to spend a certain ratio on services compared to administrative costs. All of this financial reporting was new, and in fact, the Senate played a great role in adding that to the reform proposals. Yes, sir. The question is there any measure to see how quickly managed care plans pay vendors and what they are paying for? So we can see what they're paying for, but that's the encounter data that I'm talking about. We can see for every patient encounter that every patient has with any provider, a therapist, a doctor, a hospital, a nursing home, we can see that come through. The encounter data is just based on the encounter. The claim, whether the billing is done timely, there are some contract requirements for how quickly a plan is supposed to pay providers. There have been difficulties with that, I would say, particularly in some particular areas. I would say that where we have problems with that, ACA needs to be made aware of those issues. If ACA is not acting on being made aware of those issues, that's something each of you and I can help with. So if you're hearing from constituents, from providers that are having billing problems with plans, I'll show you later, there's a complaint hub that provider needs to use to report it, just so that it's documented, so that ACA can see that there is a problem. And then you and my office can work with the Legislative Affairs Office at the Agency for Healthcare Administration to try and get compliance there. The agency has issued penalties and sanctions against plans when they've seen problems documented. So we can help with that if you're hearing from constituents. I'm not sure what you mean. I'm not aware. Sure. Okay. Representative Geller, you hold on just a second. I think his question is to managed care. That's what his question is to.
Is there a direct, any issues here of direct state payment via
I think the question he's raising is managed care organizations questionably timely paying providers. That's the question he's raising.
pretty much as part of this kind of here, so really the state is kind of out of that business for this component in terms of the state having.
In general, the state is not in the business of directly making payments anymore. There is still a small fee-for-service component, but in general, the state's role has moved to contract management and holding plans accountable, or at times perhaps not being aggressive enough on that. That's the shift in functions.
Would you talk about this something where these managed care plans are simply not in a timely fashion paying the providers for the services they were rendered?
Of course. Well, you're raising important issues, and and we would be happy to help set up a meeting with ACA for you to talk with them about the problems that you've been encountering with specific plans. One of the most exciting things I think about the newer Medicaid program are the innovations. We have a lot more flexibility with what can be done in Medicaid when we're using managed care. There are some federal, I'll call them straitjackets, that limit ACA's ability to be creative. One of the really exciting things is the potential for specialty plans. The legislature told ACA, hey, if anybody wants to do anything innovative to really focus on some high problem areas, chronic disease, patients that are high risk and high cost and aren't getting good care in the traditional Medicaid program, be open to that. Negotiate for some specialty plans. Let that happen. We thought that we would get a diabetes plan or something like that. What we got was even more than we hoped to get. Right now we have specialty plans for child welfare. That's a really tough area where you've got kids who are moved in and out of homes, maybe in different locations. Maybe they had a family doctor before they were removed from their home. Maybe they never have been to a doctor. Now we have one plan statewide that is focused on making sure they get continuous coordinated care. And we're finding that the data isn't great for foster children. We've never really focused on them in that way before. So there's great potential there. Did you have a question? Okay. Another specialty plan we have is for folks with HIV/AIDS. This is a group that if aggressive care management is engaged with it, they can see better health outcomes. And so we've got a couple of those plans that are focused on those folks. We have a specialty plan for people with severe and persistent mental illness, which is a very high risk group. Folks that it's very difficult to get them care, and that flexibility really comes in with that plan in particular. So the company that's running that product really, in working with that group, discovered that housing is a big issue for those folks. If they are homeless, it's really hard to treat their mental illness. So they're using their flexibility as a managed care plan to pay for housing supports so that folks can get into a safe environment and then be treated better. That's a service that we've never provided for in Medicaid, and they're providing that at no cost because they want their measures for mentally ill people to be better, and they know they're not going to improve while people are living out on the streets. And then, of course, we have the more traditional chronic disease specialty plan, diabetes, COPD, congestive heart failure, and cardiovascular disease. So for the first time, we're really taking those groups who choose to enroll in those specialty plans and focusing on them in a way that we never have before. This is just a quick policy comparison. I won't belabor it. It just shows the evolution of our policy and managed care through the years. Our old program, our reform pilot, and our current program. And you can see in each instance we're adding accountability measures and data collection and transparency and fiscal accountability. Yes, sir.
So when you spoke about the pilot program, you said that Medicaid was anything you alluded to Clay, Baker, Duval. Obviously that's a region. Is that Broward?
It was Broward and then Duval, Baker, Clay, Nassau.
So I'm focusing on the region part of that. Is that the region that was in that 5-county pilot?
It was kind of two separate areas, obviously, in the state to try and get.
But then the thought was if you pick just Broward and then pick the region also just to compare the two.
The legislature chose the locations, but yes, we wanted an urban area so we could see how it would work there, and then we wanted an area with an urban core in Duval, with significant rural areas surrounding it, to see if we could get better care penetration in those rural areas. It's really hard to get providers in those areas. It's really hard to get managed care in those areas. But if you have an anchoring urban area like Duval, and the plan is forced to cover those rural areas, if they're going to get the very nice urban area with lots of enrollees there, then they do a better job taking care of those rural areas. So we were trying to combine the two to leverage the economic incentive again. But to your question about the regions, these are the Medicaid managed care regions. So remember one of the lessons that we learned was that we had too many plans and too much volatility. Now we competitively procure the plans. It's not any willing plan that comes in the door. And we set a certain number of plans, maximums and minimums for each region, so that people have a choice of plans. That's a federal requirement. You can't just tell them what plan to go in. There's only one plan and that's it. And we create some competition in the procurement process. Representative Porter. Question is, why not have one statewide plan? There's a couple of right. So the question is, why don't we just procure plans statewide? 2 or 3 plans statewide. Creating the regions this way creates that economic dynamic that we're talking about. If you have one statewide plan, they might not focus on those rural areas so much. So we tied the rural areas to the urban, and we gave the plans that wanted Miami, say, or one of the more urban areas, we encourage them to pick some of the panhandle areas by telling them, if you win in the panhandle, you also can have Miami. So creating those economic incentives, it's population, highly populated. Yeah. Right. Because it's highly populated. So you see Pinellas County there with Pasco. Pinellas is the most densely populated county in the state. So it's the number of people. And we set the regions based on referral patterns. So we're watching where people go for medical care to see what makes sense in terms of grouping these things together. There's another dynamic with a statewide procurement. With a statewide procurement, you might end up with 1 or 2 or 3, well, you'll always have 2 or 3 or maybe 4 plans. That makes those particular plans very powerful. If we really need with those plans in a statewide setting, that can create some power that perhaps we don't want. Having them compete for each region keeps things a little looser and a little more diverse. But there's debate about how many regions to have, sir. Question is whether there's a discussion about whether to change the regions in any way. I haven't heard that discussion yet. It was a hotly debated issue when the legislature passed the law in 2011, right? 2011, right? So it could be revisited, but without compelling evidence that we've got a problematic setup, it seems to be working. Right, so 14, essentially some of 13, partial year of 13, 14, 15, and now 16. So these are the plans, the regular standard Medicaid managed care plans. You can see what regions, what plans are in what region. When folks come in to talk to you, you've got some contact information. When constituents call you with problems, here's some folks that you can reach out to in addition to filing a complaint with the hub or talking to ACA or getting help that way. And the second half are the specialty plans that I mentioned before, the HIV/AIDS plan, the foster child plan, etc. One of the other innovations that we saw are expanded benefits. So the plans have to compete at ACA in the competitive procurement to get a contract at all, but then they have to compete on the ground for the enrollees. People signing up for them get to choose what plan they want. And so a lot of the plans, for both levels of competition, offered products and services that we've never seen before. Brand new things that are being offered in Medicaid, or additional things. So we already cover physician services, but plans are covering more visits than Medicaid normally covers. All of these expanded benefits are at no cost to ACA and no cost to the state. They just want to compete and they want their measures to improve, so they're willing to invest. The most exciting one on this list, I think, is adult dental. In the current current federal scheme of Medicaid, adult dental benefits are very limited. You get dentures and you get emergency procedures for things like infections, and that means extractions. So you get extractions and you get dentures. Obviously, dental health has a lot to do with the rest of your body's health. If you're having a dental emergency, you're going to an emergency room to get a tooth extraction. This is not an efficient way to get health care. The plan said, we want to attract enrollees, we want better overall health care, we don't want to pay for these ER visits, we're going to offer full adult dental services, including preventive care. All the plans have done that at no cost to the state. ACA tells us that the plans have paid more than $85 million in adult dental benefits not previously covered in 2014 and 2015. And then you see the list of the other kinds of services that plans are providing. Not all of them provide all of these, but a lot of them provide most. Yes, sir. Sure. So the question is about the provider networks of dentists. Do we have enough dentists? Are they paid sufficiently? Some of the questions that you may have heard about from stakeholders on this issue. So OPAGA, at the legislature's direction, recently completed a report on dental services, and they found a few things. One thing they found is that managed care dental services, whether it's a separate contract for a prepaid dental health plan or through these managed care entities, pay more for dentists than the old fee-for-service system did. And I think that shows you those economic incentives at work. The plans are held accountable for higher performance on dental care than we have had in the past. And to do that, they have paid dentists more. They're also using other tools besides payment. The plans are responsible for transportation, for example. So if a mom hasn't gotten her child to the dentist that year, the plan will work with the mom to get the appointment, get her child to the dentist, and we're seeing improvement there. We saw a 10% increase in child dental visits since we did the statewide managed care program. Did I get to all your question? Did I cover it all? Okay. We'll be happy to send it to you. It just came out last week. I think you talked about number of dentists in the network, right? So the number of dentists in the network did increase as a result of the statewide managed care rollout. It was not a tremendous number increased. Perhaps it's more important to look at the fact that we see more visits, regardless of how many dentists there are. But we did see an increase. Well, we've always covered children's dental, full children's dental. That's always been a Medicaid coverage issue. And that's really where the focus is, the performance focus, to get more children's dental services out there and have kids getting to the dentist and not have those emergency events with children. The adult dental side is something we didn't do much with, and now we have a full benefit for adults. These are some of the performance measures. HEDIS scores are national level. Oh, excuse me, Representative Geller.
I just wanted to say on that last thing, I know that, kind of collectively, we usually have a lot of issues when it comes to your operations and things. And it just really sounds to me like a really outstanding outcome, no cost to the state, that much more coverage. I just wanted to take a second to recognize that. I think that's a really wonderful thing that you've done for the citizens and not at the taxpayer expense. So, good job.
Well, thank you, but to be clear, I didn't do it. I work for the legislature. It's ACA who negotiated those contracts and encouraged the plans to be innovative, and it's the plans who came forward and offer these things.
The state.
It's a tremendous accomplishment. Yes.
It's just, for once, I mean, that's one that worked, and I just think that we should note that when it happens. We don't hesitate to note the other.
Agreed. Thank you. So this.
We're mentioning that we had a concept that we all thought was true is, early you get care, cheaper the care cost is, preventive care and all that.
So these are the performance measures. HEDIS scores are federally set standards for improving performance in healthcare. And this is a very high level view. The agency has all of this data online. You can break it out to see the actual measures or the bundles of measures of how people did. We'll see a little bit more about that in a second, but you can see our performance is increasing the last few years. The blue areas are areas where our plans are at the same level as the average nationwide. The green areas are where we surpass the national average in Medicaid managed care plans. So you can see performance is going up, which is a great sign. The next slide are the complaint issues, which I just referenced briefly. ACA created an electronic hub to track complaints in the new program. They were concerned that a big rollout, a huge change, there's going to be friction in the system. There's going to be stuff that falls through the cracks. They wanted to know about it. So they created this online hub. People can call in on the phone. People can get online and file a complaint. Providers can do this. Recipients can do this. And then ACA tracks the spikes in complaints, where they are and what type they are. So this is just a quick overview of a little over a year showing you the types of complaints: transportation issues, durable medical equipment issues, and you can see there's some variety there. ACA, I think, has been pretty engaged at getting on some of these issues. We had lab issues in the beginning, some therapies issues in the beginning. Those things died down a little bit, those complaints. These are in the thousands. So given the millions of people in Medicaid program, this looks not too bad. I will tell you that I think complaints are underreported. We hear from your constituents all the time. We hear from advocacy organizations that there are issues that they're not reporting. It would help if they would report them so that ACA could track them and see whether they have just a few one-off problems or a systemic problem. But we certainly do have some underreporting of complaints. Yes, sir.
I apologize. Can you go back one slide? Sorry,
Oh, yes. Mm-hmm.
Can you explain that again? I went
Sure.
fast. I didn't understand why there's the blue. This is the amount older than national average.
The blue are the areas where our performance measures are at the average for the country, where we are on par for what everybody else is doing. That's the blue areas. The green areas are where.
What would that mean? That doesn't work.
I'm sorry. Let me put it a different way. So
But let's assume there is no green 2013. It's just blue.
that would be terrible. That would be terrible.
So what does that mean? That means
Our performance would have tanked.
that means our performance is at the average.
And yep, and that's all it is. We don't want to be average though. We want to be better than average.
So what does performance better than average mean?
The performance better than average are the green slots. So the ACA looks at the HEDIS scores for all managed care plans for the whole country. All of this gets reported to the federal government. We see all this data coming in, and they can see that the HEDIS score for prenatal visits or whatever the scores are measuring, they can see the rate at which people are getting that care, and that registers as a score. And so nationally, that score might be 50%.
So an improvement is more people getting care.
Yes.
It's not whether they're getting better care. It's just the number.
No,
of visits.
no, it's not just the number of visits. It's actually measuring outcomes in many instances. Sometimes it's the number of visits, like the number of preventive dental visits. That's a good measure, but the actual outcome is what we're looking for.
But for instance, just to clarify, is are you doing breast cancer screening? That's new. So it's not just that you saw a person at the office. If this was a woman who was a breast cancer rate, did you assess her for breast cancer? Hundreds.
Right, hundreds of them.
Hundreds of going to the agencies.
And they bundle them into different categories, and this is the highest possible look at this type of data. But the point is that our HEDIS scores are going up and up and up, and that our measures are better than other managed care plans in the country. They're not great.
So this
not-
number doesn't mean value, like
Right.
for every dollar spent, we're getting more coverage. It's not.
No, it's not a coverage. It's not a coverage measure. It's a healthcare outcomes measure.
Okay. So what does HEDIS stand for?
Trying to remember. Health. It's a long acronym for the federal government, and I'm blanking on it right now, but I can get you that information.
So I mean that would help me. to understand
Dr.
what
Gonzalez can
measure.
tell us probably. The agency website breaks down all of those HEDIS measures. I've only given you the very high average, but we can send you the link to that website and you can see what each measure is. Dr. Gonzalez.
So is there, where we're performing below average or is there?
This just it only shows the areas that where we are performing at or above average. There are areas where we're performing below average. Those are improving as well. That they're not shown here. But these are the averages overall. So overall, we are improving, not declining.
So we just moved, these are these 5 different parameters, H, E, D, and all that?
No, hundreds of them, hundreds of measures. Yeah. So these are the actual scorecards for the plans. So those HEDIS measures are here broken out into how the plans individually are performing, and all of this is online. The website is there. So you can see how each plan is performing. In each of these columns are different buckets of HEDIS measures that ACA's grouped to try and reflect how do we do with pregnancy care, how do we do with children's dental, how do we do with chronic disease in adults. You can go to the website and see what all the measures are for each of those, how many HEDIS measures are involved in those. These are the specialty plans measures, and you'll notice that there are, in many instances, fewer stars than for the standard plans. We have to be careful in interpreting these specialty plan measures. Remember that the specialty plans, all of the enrollees are very high-risk patients. They're all people who have serious problems health-wise and cost a great deal. We've never looked at those groups all together before. They've always been mixed into the general community before. Now we're seeing them all alone in this group, and we see the performance is challenging. It's hard to get control of improving healthcare for these groups. So these specialty plans have some challenges before them. Representative. Sure. Question is, how do we deal with folks who aren't performing well, with plans that are not doing well? There's several ways. So first of all, the agency has the ability to institute financial penalties against the plans that aren't doing well, and they have issued liquidated damages against some plans in some instances for failure to perform. We do have a regular reprocurement process. These contracts are for 5 years. The new reprocurement process for the plan year beginning at the end of 2018 will start next summer. So folks that haven't got their numbers up by then might not have as good a relationship in terms of negotiating a new contract with ACA. Another, I think, important way to hold the plans accountable is your involvement. When the plans come meet with you and they want to talk to you about some problem they're having with ACA or some issue they have with the law, get your aide to print these out. Print out their scorecard, and when they come in, talk to them and ask them what they're planning to do to bring that number up. What have they been doing on that issue? Your attention and awareness can be much more important than anything ACA does to them. We didn't talk about long-term care very much. We moved to long-term care and managed care as well as part of this. The goal of long-term care is to get people out of nursing homes and into a home and community-based setting. People don't want to live in nursing homes. They're a lot more expensive. We didn't really have anyone to hold accountable for how to do that, and now we do. We have a plan that's taking care of both the home and community-based services and the nursing home services. We told them that we want no more than 35% of the Medicaid long-term care population in a nursing home. Flip that ratio and push diversion and push getting people supports in the home. So the plans are helping build ramps in people's homes. They're helping design those community supports so that people can stay at home. And you can see that the ratio is moving. Nursing homes compared to home care are going in the right direction. And we created economic incentives to make that happen by cutting their rates. So if they don't get people out of nursing homes, they're gonna not survive financially. And it seems to be working so far. These are the Medicaid managed care long-term care plans. If you get contacts from those folks or concerns with people's home health care or other issues, you can talk to these folks. So this is some impact that we've seen as a result of Medicaid managed care. You saw the cost, the big cost graph that we saw before. The whole program costs more money every year. Most of those new costs are because we are treating more people. More people have enrolled. This is what the costs are per person, how much money Medicaid is paying to treat individual people. And that cost is going down, which is a fascinating number. So some of that is, for example, the nursing home population. Nursing homes, the fewer people you treat there that you care for in the home, that's less money. what this shows is that the care management appears to be working. We're preventing catastrophic bad events from happening. If plans were systematically denying care, we would see a spike in those crisis moments, but we're not seeing that according to this chart. Now, this doesn't mean we're saving money in the program, because remember, we have a lot more people every year. So the costs are always rising for the program, but the costs per individual are going down. Yes, sir. That's such a good question. It came up yesterday. The question is, well, maybe costs are going down because we've got all these children and they're low cost. I think that that's probably an element just for the last year, because we really have only had that big influx of children since 2015. But we're also seeing reduced nursing home use and other management techniques. I think if we hadn't taken on 500,000 more children, that slope might not be as severe, but it would still be trending down.
And also, this graph is really a little bit deceiving. The bars are only $200.
It is.
It makes it look like a bigger decrease than it actually is.
Right. It's a small decrease. That's true. But remember, this is for millions of people. So it has not trended down before. So that's a significant, the fact that it's doing that at all.
So I guess the answer to your question is, if you do the number with children, without children, you kind of see how that works.
Yes. Yeah. Representative Connie. Yeah. The question is whether we forecast based on population growth in the state, and that's absolutely the method. The state economist and the House and the Senate, the governor's office do estimating conferences together, and we chart out what that expectation is. So yes, we do. Now, I don't think we expected this big bump in children. That was somewhat unexpected. But yes, we absolutely chart out expected enrollment based on population growth. Which, yeah. So we pretty much have run out of time. I just want to flag some areas that I think there's room for improvement. Some of these questions have arisen today. Network accountability is a big issue. Long-term care billing is a big issue. The nursing homes recently brought us problems related to that. We can improve in quality. We can improve in our complaint submissions. This is where we're going next. We are renewing the waiver. AHCA is negotiating that with the federal government now, and we'll re-procure the plans next summer. Yes, sir.
Go back to slide 5 real quick.
Sure. Is that the one you're looking for?
Okay, so there was obviously a flattening there. Why the increased trajectory from 08 to projected 2017? Because
That's the economy. So you see it flatten out, 2006-ish. Things were going pretty well then. Yep.
or at least when you look at it on a more macro level, if you take like 93 to 90 to 99, it's
So-
pretty much flat on average.
Mm-hmm.
When you look at 2000 to 2006, the growth of the caseloads, and those were obviously decent times, but there's still a growth there, but it's so steep. You're saying that
Some of it is the rate of people moving to Florida, which fluctuates depending on what's going on in the country at the time, and economic conditions. Yeah. Well, thank you. I've kept you far longer than you were supposed to have been kept. My apologies. If I'm free for questions up front if you have it.